As a speech and language therapist, my role is to assess, diagnose and treat patients with swallowing and communication difficulties.
As stroke physiotherapists, we are specialists in analysing movement, and part of our treatment is to assess and treat movement disorders and balance problems, and then facilitate activity and function on top of that.
As an occupational therapist on the stroke team, we would assess and treat patients through using purposeful activity or through using activities that would restore, maintain or improve their current levels of independence.
Not everybody loses their language, but as human beings we are communicators, so it is a devastating effect for people that have lost their communication, and it takes time and a lot of counselling for them to come to terms with that. With the swallowing, I'm making sure that the nurses know what the recommendations are and the best way of feeding the patients, whether that be a slow-paced feed or whether they can manage a little bit more pace with their feeding, and also what type of fluids that they use, whether they're thick fluids or thin fluids, and how many spoonfuls of the thickener we put in their drinks to make it safe for them to drink and eat.
Well, following an assessment of how they move and what they're able to do, we would bring them into the gym, do some exercises with them to try and facilitate activity, and when possible getting carers involved as well, so they can see what they can do with the patient as well.
The type of assessments and treatment that we've carried out would be through washing and dressing assessments, domestic activities of daily living, through seating and wheelchair assessments. We would do upper limb activities, look at their sensation, do splinting, and the other areas is cognition and perception. We do a lot of standardised assessments so that we can pinpoint those areas that may be a problem.
Counselling patients is always difficult, and people want to know how soon it is before they get their communication back, and that's always a difficult question because we don't know.
There's lots of constraints really. Patients might be medically unwell, or they might not be very active beforehand, so that all has an effect on their rehab as well.
I think the area of stroke, you always feel that you could spend more time with any one patient. There's a lot of different areas with patients that we can cover, and we don't necessarily always have the time that we'd like to.
We're all part of one district-wide team that are actually employed by the community trust, and as such our service is seamless, so we transfer patients directly from the hospital or the acute hospital service to the community. We
make referrals for follow-up. When patients have gone home, we might arrange for outpatients, so we would do a transfer letter which we send to the physiotherapist, so information that we've got is passed to the outpatient team. And also we might contact the community hospitals if patients have gone there to again give feedback about the patient. We have one formal meeting a week usually, but then therapists, the fact that we share an office, there's a lot of ad hoc communication among staff that way, and we have reports from the nurses in the morning, which again is another two-way process where we feed information in and they give us information, but that's also attended by the occupational therapist as well. So again, it's a big MDT approach to the patient.